It's a pleasure to be here. I really enjoy coming up to Wisconsin. My daughter lives in Hudson on the west side of the state. I got a daughter down in Chicago. I've been to Milwaukee, this will be the fourth time. Just spoke here in 08. I was here in 12 for some of my myofascial needle therapy coursework at Marquette. I was here in 2014. I'll mention that in a second too. We're going to talk about the chronic pain side of things. We talked about perioperative pain when I was here last. And the point with chronic pain, and hopefully by the end of the discussion, you'll have a few more tools in the toolbox that if all you have is a hammer, it looks like a nail. And even if it's a golden nail or a golden hammer. It's going to be tough. So it's getting late. You've had drinks, just had dinner. It's going to be tough. So keep the coffee flowing. I always like to compare where I'm from and where I go. And I thought pretty similar cities when you think of it. This is Buffalo, from our waterfront, Milwaukee. Two cities, not huge, but some size on the shore of one of the Great Lakes. So we have a lot of water fun in the summer. We get a little bit of snow. And then I was doing some digging, and I guess we get some snow too. So we're kind of brethren in that regard. So last time I was here in 2014 was actually to watch the air show. You might wonder why I would come to Milwaukee for an air show. My younger brother Bill is an aerobatic pilot. So he'll be at the show this summer. 2014, I don't know if anybody tried to go to the air show, but they never had the air show. So I spent a lot of time chatting with all the pilots that were hanging out on the other side of the airport. We had a lot of fun. But Bill will be there. He'll fly some solo work and some combinations. So if you do go down to the air show, you'll hear his name. It's really important for me to point out that what we do in an aged facility. It's in the corner of Buffalo, New York. Buffalo's not remotely a well-to-do area. Sounds like that's echoing a bit too much to me. You don't need a fancy Taj Mahal to practice good anesthetic and perioperative pain management or chronic pain management. So we're going to talk about things that everybody can do. I'm definitely one of the older dogs in the room. I did graduate from Michigan State in 1980. I had a couple years in the Army, so I was a little bit late down the road even at that. So I learned a few tricks along the way. I think it's a key part of pain management. And what you need to do can be done without spending a lot of money. You need a little bit more time, a little bit more understanding, a little bit more knowledge, but you don't need a lot of equipment. And honestly, we'll talk about cases, patients that have gained years and years that otherwise would have been put to sleep if they had not reached my door. And on average, I think we can gain a lot of time for our patients. This is a little Ginger, just a great example. She came to us, a little Beagle mix. She was 9 years old. Chad, can you make that echo less? I'm halfway down here. Yeah. So Ginger came to us at 9 years of age. She had severe back pain. I mean, squealing, crying, really severe back pain. I lose my voice if I talk real loud on our insurance side. So she came to us with really severe back pain. Her veterinarian had run through about 10 or so days worth of anti-inflammatory, muscle relaxant, outpatient therapy. Cortisones, a round of cortisones and the methylpredamol, a round of non-steroidals and methylpredamol. And she was no better. And she was just squealing. Couldn't positively defecate, eliminate. So the veterinarian gave them two choices. They said, either you put her to sleep or you have surgery. And they were not going to have surgery. It was just not on their list. So they'd actually made an appointment with our local SPCA for euthanasia. They found out about us, came in for a visit. We discussed a variety of options: needle therapy, a more multimodal-oriented neuropathic pain medicine therapy. Initially, they actually only let us do the medicine. I wanted to do needle therapy right out of the gate, but they didn't let us do it right away. They thought it would be like a one-session deal, not a series. And so we got about 10 days down the road from our involvement, about 3 weeks down the road total, and she was still squealing in pain. She had one of the most obvious allodynic components, and if you study pain and you understand allodynia, that's the perception of pain from things that are really sensory bits of information. You're putting on your clothes brushing against your skin is painful. You just brush her left her leg and she would squeal. She's the nicest dog, didn't want to bite anybody, but she would just shriek. Well, suffice it to say, we were 20 days in total. She was only 5 or 10% better. They finally let us do needle therapy at that point. And the day we did therapy, it's actually the most dramatic of all the cases I've done needle therapy. And the day we did needle therapy, she was 90–95% better by the end of that day. And she didn't look back. We did 2 more needle sessions. We phased her off her pain medications. She lived another 8 years. She lived to 17. Never had a reoccurrence of her pain, which actually probably surprised me more than anything. And she'd been put to sleep if they hadn't found out about it. And actually, there's another interesting point there. Right again. One of the other interesting points was that the primary veterinarian, he actually did not want to participate in referral of our practice because we might do acupuncture. He had such a negative mindset. It's really an interesting perspective. So we're going to talk a little bit about the foundations of pain. I just can't help but talk a little bit about that. The question is, what is this thing called pain? Is it a brain problem or a joint problem, a muscle problem, a spinal problem? It's really a complex, very diverse experience. It's not the same thing for each person or patient. It's not the same even if you all have knee arthritis. So it's a very different process, and we need to have a very dynamic treatment option. We know that physiologic pain is protective. We know that some pain is good. There are actually people that are born without pain awareness, right? Congenital analgesia. And it is not good. You might think, hey, you don't have to worry about pain. They actually have a pretty short life expectancy. So physiologic pain is pretty crucial. And then acute pathologic pain, pain associated with injury, it's certainly nice to be reminded that you twisted your ankle and you should take it easy. But once things heal, once you've gotten all the healing done that can be done, and you look at that area and there's just everything seems fine, you should not have pain, or at least you don't want to have pain. But that's the chronic pain state. It really is a cruel malfunction of the nervous system. And it is something that really needs to be looked at as a separate disease. So this is my really fast version of the study of pain management. We used to think it was really simple. There was a switch, an injury would flip the switch, simple wiring, click the impulse to the brain. The brain was a light bulb, the light bulb went on, you went out. And then once everything healed, and the doctors looked at your foot, your site of injury, and everything was completely healed, the doctor was convinced the switch was turned off. And if you still complain of pain, that's when they used to tell you it's all in your head. Because they just couldn't figure why you should be in pain. Your foot's fine. We know now it's much more complicated. The wiring is not simple. The relays and switches, the whole mechanism, it's incredibly complex. And our brain is not a simple light bulb. So we have this phenomena whereby this normal pain response curve, this is how things should be, that to the left here, nothing should hurt at all. But when we have significant pain, this pain response curve shifts to the left. So things that should hurt a little hurt a lot. And this is that allodynic corner. Those are things that shouldn't hurt at all. And that is a real phenomenon.
I'm not sure if any of you have experienced that here, but it's a very serious issue. Genetics, I like to talk about genetics to a degree when I can, but pharmacogenetics, it's a developing field. They are starting to do that on the human side, do some testing before they start therapy to better match us with our treatment, our medications. But we don't have a Star Trek tricorder yet. My last Jack Russell was named James Tiberius, so I have a pretty big fondness for the Star Trek show. But the idea of having a tricorder, quickly scanning our patient, trying to decide who's a high metabolizer, who's a low metabolizer, who's a high responder to medicine, or a low responder. The idea of what adverse effects you might be prone to. Someday we'll figure that out, but that's not now. So we have to be more broad-based is sort of the theme. And the simple truth that Leigh Lamont printed BCNA some years ago, something that hurts to a person should hurt, we should certainly assume it hurts to for an animal, for one of our patients. And if you don't go home with any other reference or any other plan other than to pick up this book and read this particular book, it's a really well-organized book by two neurologists, Dr. Wheeler and Argoff, are two of the leading pain specialists on the human side, and it's a really great review of chronic pain. And I recommend this because whenever I talk about chronic pain, and I know my life experience, and I know there's some older people in this room, you're not all under 30, that chronic pain is a reality for all of us. This is a great reference to guide you and your family members as they approach their various pain problems. So I highly recommend it. So I always like to ask, what are the top pain conditions? Was that a complete list? It's a fact that I'm going to concentrate on cancer pain and osteoarthritis because we don't have much time, and I'll be hard-pressed to get through those two. But not as many people in the profession, human or veterinary, are aware of myofascial pain. We'll talk briefly about it. The idea about trauma pain, Marla may appreciate this picture. This guy survived. It's going to be hard for some of you in the back to see the lower part. He's got this big pole right through his chest. The idea of chronic post-surgical pain, that is a chronic pain condition. We're not going to talk about it, we did a little bit last time. But what surgery is just a sort of a planned trauma. Right? It's an intentional trauma. And the idea of these little kitties. I adopted 5 kitties. I have 4 daughters, and we're on vacation in Florida in '95. And there's this little feral, semi-feral queen, and she's got her kids outside of a restaurant we were at. My daughters were convinced we should take all the kittens home, and we talked about starting an adoption program at our practice. And we driven to Florida, and it's an 18-hour drive back to Buffalo. And we did pick up 5 kittens, and we thought we'd keep 1 or 2, but we kept them all. So by the time we drive 18 hours, the kids range from like 3 to 10. They're also completely bonded with those kittens. But they all develop chronic inflammatory bowel disease, chronic ebbing and flowing, and chronic pancreatitis. The idea that these kitties can hurt and managing their pain can be a big part of giving them a much better quality of life. So that's the Cliff Notes fast version of pain history and the basic facts. So what is optimal chronic pain therapy in my mind? Having studied this for quite a while. And then this is all really being spurred to a great degree by the fact that I've had really significant chronic lower back pain for 30, 35 years. So as a patient, and actually having to sort of self-investigate a lot of things over the years. But this is what we want chronic pain to be. This is what we want the condition to be. Straightforward, easily correctable, want to resolve quickly when we address the cause. You have a cruciate failure, an unstable knee, and we operate the stifle, and we want everything to get better. We simply want a target with a solution. We'd like it to be a light switch and a switch. We'd like to think, well, I still feel pain, I just need to swap out the light switch. Maybe need a new light bulb. But this is what it is. Unfortunately, it's a headache. That's why 20 to 25% of the world's population suffers from chronic pain. Not not an easy target. That's not easy when you're verbal and can really give your doctor some good clues. And there's health insurance and some specialists. You'd think that that number would be lower. So we're not talking about 20, 25% in undeveloped countries. We're talking about in developed areas like the U.S. So it's a complex process, a disease in its own right. When you talk to the human pain specialist, I was at the Cleveland Clinic Pain Symposium in San Diego a couple years ago, and that's all they talk about. Is how do we get our colleagues, how can we convince them that chronic pain is a disease, a separate disease? It doesn't matter what started it. I mean, it doesn't really matter. You address what started it, but you still have work to do. So even when you remove the initial cause, go mouse, go. The pain may not resolve. There's no better example than this. What could be more straightforward? You've had hip pain or knee pain for the last 20 years of your life, and you're going to go have that knee or hip replaced. We're talking about human. Talking about the human experience. And you want to think you're going to have that surgery done, you're going to wake up, it's going to be a little uncomfortable for a while, but in your mind, you're not going to have pain coming from that hip or knee. And it's not hard to find studies. Upwards of 47% of the people that have a knee or hip replaced, they still complain of pain from their knee or hip. We're talking about a surgery that's done perfectly. And yet, the patient still has debilitating pain that their brain thinks is coming from that joint that's now in the trash can. So that's what chronic pain is. That's how it works. And what do we want chronic pain therapy to be? Well, we want something really safe and convenient. You know, veterinarians like things straightforward. We like it does it all. We want it to do everything. One thing. It's all in there. Unfortunately, it's not a laser. As much as I like my laser and I use it, I've seen too much dependency or a sense of monotherapy being enough. And it's a decent supportive modality. I did my rehab training with Canine Rehab Institute. Anybody Canine Rehab Institute? The rehab here? Okay. So certainly we talk about the usefulness of laser therapy. We did rehab training. We did in a myofascial needlepoint or needle therapy, trigger point therapy class work. But too many people set their laser to stifle and they treat the stifle and they don't look at the rest of the patient. They don't treat the rest of the patient. They're not looking at all the areas that need to be treated. If you have chronic knee or hip issues, you probably have hip flexor issues. You have Achilles psoas. You better look at the whole patient. So I'm just afraid there are too many Dr. Evils out there that take Sparky and use their laser beams, and they try to fix everything, and they think that's all they need to do. So it's good to have one. It's not enough. And then discussion of laser power, 3Bs, class 4 lasers. You can talk about power of a laser all the time. The companies that sell them try and convince you of different advantages. As far as I'm concerned, real power, that's real power. You go out and you get more knowledge. You go to rehab classes, you go to acupuncture classes, you study the IVPM pain medicine coursework, you go to their meetings, and then you get a laser. But I just hate when people spend tens of thousands of dollars and then they don't have money left over to go to class work. So that's how I look at it. And chronic, if you go to the Cleveland Clinic and you go to their pain service, they have a team approach. They sit around the table, they talk about you and your problem and who's going to do what. They have acupuncturists, and neurologists, nurses, and doctors, and occupational therapists, and physical therapists. And they're not in different rooms, and you go to one and then the next, and you're just parading down the hall. They're talking about you together. So it's an interdisciplinary process where one specialist understands the value of the other. They're not turf warring and trying to protect their own. They're part of a global awareness. You have to look at the patient in a thorough way. So I think the top three are pain medicine, rehabilitative therapy. My mouse is playing tricks on me a little bit. So the top three, I think, are the ones that are the easiest for you to pursue. There are lots of options for developing these aspects of your practice. And the other supportive modalities, I think chiropractic is at the top of that list for me. That's a little harder to pick that one up. You're not gonna pick that up on a weekend course, just read a book, right? So I'm gonna focus on the things you can do and you can develop pretty easily, I think. So optimal diagnostics, I do think you have to develop your patient understanding to a degree. I think the most important thing is my hands-on evaluation, what I learned with my hand. I'm really looking at the joints, I'm really looking at the muscles. I palpate my dogs, all my young dogs, so I can kind of tell how much pressure doesn't hurt if you have normal muscles and you're not subject to any particular chronic disease. So I certainly put this as my top priority. Imaging when possible. I'm pretty sure if they have arthritis in a joint. I'm pretty sure if they have a bone tumor, or at least I'm pretty suspicious if they do. I'm thinking about that, probing for deep bone pressure. But I certainly like to consider the option for imaging. Go now. We do not have MRI in Buffalo, we have CT, so we have somewhat limited options, but it's certainly nice to be able to include that in your workup. And when I usually talk to the client, it's, as I've alluded to, I'm not usually intending the radiograph to prove there's arthritis. I'd like to know if there is, but I'm pretty sure going in if there is or isn't. And if I have obvious evidence of an arthritic disorder, then I focus my therapy on that. If I have obvious cancer-related presence, I bring certain therapeutics into the mix that I wouldn't otherwise use. So it's really important. If I have a discospondylitis, I'm going to use antibiotics. I'm going to treat differently. So if I have spinal pain, non-specific spinal pain, I'd like to have some x-rays, at least. So they help shape my therapy. Bisphosphonates if I have a bone cancer, metastatic or primary. Antibiotics if it's infection-related, osteoarthritic support that we'll talk about. So this isn't Brutus, but Brutus was an aging American Bulldog who came in last year. And he had his right stifle undergo an X-cap and surgical procedure for cruciate failure 10 years prior. So he's a big boy, he's 10 years down the road. No one would be surprised at the suggestion that there's some degenerative joint disease in that right stifle. So when he developed a significant right hind leg lameness earlier last year, he was put on basic medications, and when he didn't really respond, the clients actually were bringing him up to their veterinarian. Why don't we take some x-rays? And they said that they repeatedly asked their veterinarian. So this is a service you can provide that makes you money. And it does gain you some insight regarding your patient's status. And he kept saying to them, well, we're just going to see arthritis. We know he's got arthritis. So this is what we saw. It wasn't just arthritis. And I was pretty sad because when I saw Brutus, I knew he had cancer. And there's really no other explanation by the time I saw him. And we took the films to confirm what we believe to be true. And I just shook my head at the lost opportunity. If we had detected the bone cancer 3 months prior and started bisphosphonates earlier, I think he would have had a brighter future. We got 4 months out of Brutus, but man, a big dog with that, I mean, there's no bone left there. So it does make sense to take some films, but I really emphasize the need to avoid tunnel vision. The idea that you want to treat just one problem or what you think the primary problem is. You want to look at the whole patient. You want to treat the whole patient. And don't treat radiographs. That book by Argoff and Gaylor, they talk about how radiographs often don't show the cause for most of the human pain conditions. You don't see nerve-related changes, central changes in the neural pathway. So they argue that too many of their colleagues take an X-ray, see something on the X-ray, and then they just sort of think their job is done. And if we took x-rays of everybody's spine and anybody here over 40, we're going to see something on the images on most of those people. So the idea that you see something on a radiograph or imaging, you still need to put it in perspective, and you have to look at the whole patient. So you don't want to find a problem, you want to find all the problems. Good history helps you think it through. And the idea is, I've alluded to, you really have to look at the whole patient. And I do. I look nose to tail. It doesn't matter where I think the primary problem is. In fact, I always start away from the primary problem. And I like to observe gait. I have an awful eye for just looking at things. I took dairy science and beef science back in Michigan State pretty bad, trying to judge these the host stock. I don't have a very good eye for that. I need to video things and slow it down. The newer video form, you can take amazing high frame rate, slow motion video with your cell phone. And slow it down, you can see head bobs and tail bobs, really be more, I think, clear about what's what. So the idea of creating hope, I can't tell you how crucial I think that is. The idea that you have a patient who comes in and has god-awful hips. The first thing you need to do is not take an x-ray or whatever, but if you look at the client and go, oh my God, these are the worst hips I've ever palpated in my entire life. I don't know what we're going to do. Joey's the size of a horse. He's 80 pounds overweight. It's going to be tough. Nobody's going to have the right attitude in that situation. So you need to be able to say, look, arthritic hip disease is a challenge. But we're going to break it down into segments, and we're going to address each of the segments, and we're going to come up with a strategy that we think is going to make a difference, and it's going to improve his quality of life, and we think we're going to gain some ground. He's going to have a much brighter future. So I think creating hope is one of the most important things you can do. And as I've alluded to, if I have a hind-end problem, I don't look there first. I always look at the front end first. I don't want to probe the areas that may hurt the most. And I'm very interested in making sure I don't forget to look at the areas that were not necessarily part of the initial complaint. So I look at the front end and the core. I look for joint muscle pain, really interested in muscle pain. And I'm thinking about central sensitization. You don't see that or feel it. That's more inferred by the duration of the problem and the nature of the symptoms. I'm looking for the issue of compensatory components, how the hind end influences the front, and certainly thinking about weight, what we can do. So I know when I graduated in the 80s and did my surgical training at Minnesota, actually back at that time, the Wisconsin students all went to University of Minnesota. They were all there. And I was in the old building, and they were building the new building there at the vet school in Minnesota. They were cutting through pipes in the hallways, and sparks were flying. It was interesting to be in the old part of the vet school at the time of the remodeling. But there was a day where they shared that vet school. So back then, I think I had a simpler mindset. I was trying to keep a dog with a cruciate failure problem from grinding to a halt. Surgery was going to minimize arthritis, and we were going to try and avoid having the dog become non-functional. So in the past, it was sort of more of a survival mode perspective, but now my perspective is quite different. So ADLs, activities of daily living, that's what physical therapists talk about. You want to get back to what you love, doing what you like to do. My back was going south around 1990, and I like to bicycle. I want to get back on the bike. So my ADLs put me in a certain frame of mind. So there are some couch potatoes, and there are a lot of hardworking dogs, playful dogs, sporting dogs, and my mouth doesn't want to work every time. Go. Go. And of course, mixed martial arts. But I have much higher goals. There's so much more that can be done. The idea of surgery, the evolution of surgical options, trying to reduce pain signaling from the joints. But I've already told you, your job isn't done just because you replaced hip, knee, elbow, done a procedure. A lot of prosthetic options, helping patients with their functional capabilities, non-surgical, non-medical. And honestly, who here is willing to raise their hand and is aware of talking about harnesses? What? Shut up. That's pretty good, because if generally speaking, there are relatively few. Certainly in my area, my clients, my patients that are coming to me for pain and functional challenges, they're veterinarians as a rule. I have no clue about. One of the most useful ways to help, particularly big dogs, but bigger, weaker dogs, help them up harness. You got to have them for these dogs as they get older. The ability to grab that back handle when they're going upstairs, to help them up into a car or down. The accessory straps let you walk them while supporting their back end. The smaller dogs, a little dachshund or something that's paretic, it doesn't have normal function but wants to go for walks, being able to support them while you take them for a walk. Really big dogs, using a strap over your shoulder to support weight. They're really handy devices. I don't get a kickback. I don't own stock in the company. I just think it's a shame that more veterinarians don't know about help harnesses and how to train your dog to a ramp. You don't just throw the ramp up the back of the sport ute and just give them a whack on the fan and expect them to run up the ramp. So having, your notes will have this website. It's just a real simple little pictorial of how you introduce a ramp to a dog and make it more likely that they'll take to it. Are there any bicyclists in the group? I know Dale does a little cycling. There's a few, not a lot. It looks like Dr. Cressens and I have both shared the experience of seeing some of the Tour de France. It's pretty cool. I have a daughter that's spent a lot of time in France, and so I've been able to get over a fair bit and see a number of Tour de France's. This is Arrivé in Joigny. It was beautiful. I've been kind of busy lately, so I get more of my miles while I'm sleeping now. You can actually buy that. So this is how I get to work on most winter days in Buffalo. Typical snowfall. So osteoarthritis, you've got to realize we have little to work with to begin with. The dog, focusing on the canine species, a millimeter to a millimeter and a half of cartilage. People, 4 to 5. We're talking about, you could have I have dogs that weigh more than me. It's not based on weight. We're just saying that genetically they're designed differently. So we don't have a whole lot to begin with. And we already know that the joint disease is one thing. We know that we have to work on the central component. And I put this in only so it would end up in your notes. So if you really wanted to see a long list of medical publications referring to the central sensitization that occurs with osteoarthritis, you can go to those links and you can see an incomplete list. It was a fairly complete list when I put it together a couple years ago. It's from a rounds I did on VIN. This picture kind of says it all. There are a lot of targets. These are all details regarding the machinery that's activated when we have chronic joint disease. This is the reminder that you can't just treat the joint or think all you have to do is deal with the joint. This is all the stuff that goes on in and around the joint and then in and around the central nervous system. That's why we have more targets in therapy now. So I break it down. I think of the joint disease itself. What can I do for the joint? And when should I do it? I think of chronic pain, its own disease. Repeat after me, its own disease. And then the idea of the broader impact here. Really, I'm having more trouble with this constant guy. So the range of motion, the muscle strength and flexibility, all the things happen when a dog becomes arthritic. They grind to a halt, and they're not fit. They tend to be overweight. They develop myofascial tripping points, almost guaranteed. And you need to try and address all those things. The mini version of myofascial disease is just simply to say, how complicated is a muscle? It's unbelievable. All the parts, all the subunits, right down to the actin, myosin, and the titin, which the myofascial trigger point people think that titin is a key part of these little myofibrils getting stuck on. But what's more complicated than that system? The ability to recruit a few fibers or all the fibers. The ability to flex and extend a joint actively with control. The innervation, the feedback, constant feedback from the stretch receptors. It just shouldn't be a surprise to anybody. It's the largest organ system in the body. Highly complicated. It shouldn't be a surprise that there can be chronic disorders associated with the myofibril function. So the idea that these myofibrils can get stuck in a contraction knot is a reference to a collection of these small, locked, knotted myofibrils. And then if you get enough of these, you can feel a tangible, a palpable band across a muscle, within the muscle. I palpate, as I've alluded to already, all my dogs from young up. I'm constantly kind of just reminding myself of how much pressure you can apply and what they should feel like. A muscle like the latissimus, a flat muscle across the chest, it's going to be flat palpation. It's a thin muscle over the rib structure. Something like the triceps or the quadriceps, a pincer palpation, you're feeling partly for a band, and perhaps more than anything, you're trying to determine if there's pain associated with that muscle or not. And if you do enough hip flexors in those old creaky dogs, you're going to find a lot of very painful muscles. Dogs that react like you're touching them with a hot poker, just palpating the tensor fascia line. And the idea of referred pain, segmental referred pain is a phenomenon that's not isolated or just associated with myofascial trigger points, but it's a phenomenon, well-established phenomenon. Many areas of the body, areas of our body that are in a way unrelated but connect to the spinal cord at the same segment. They can have referred pain. Pain in one area can make you feel pain in another, even though the other area is fine. So myofascial trigger points, like an infraspinatus muscle of this person, that's the black dots, can give you the impression you have a problem because you feel pain anywhere these red dots are, right down into your hands, front and back, even the base of the neck, the base of the skull. The red dots are where patients have complained of pain when the physical therapist or practitioner pressed on the trigger point. So you have the potential problem with pain at the trigger point side. You have the issue of referred pain that can give you an illusion of pain elsewhere. It's just one of those complex processes that can't be totally ignored. I see trouble, some of the key areas, triceps, the latissimus, I see a lot of trouble across the lats. Dogs that are having trouble with the back end, weak pain combination, they pull. They work a lot harder at the front end trying to get up. And those muscles are very active during that sort of activity, engaged when these dogs are trying to get up from a down position. The idea, as I alluded to, the tensor fasciolatus is one of the 4 hip flexors. As you peel off the layer, the teres major that originates at the caudal angle of the scapula. Any acupuncturists here? Anybody know what acupuncture point that is? There's a classic acupuncture point there called Bolan. I deal with that site all the time. I see a lot of dogs that are really sensitive at the caudal angle of their scapula, shoulder blade. Again, it inserts with the latissimus just inside, just below the shoulder joint. And it's one of those muscles that tends to be overstressed or overused when we have hind end problems. And the core, reminding myself, it was interesting to go back to rehab or Canine Rehab Institute classwork and relearning all the muscles. The idea of how many there are that stretch across the thoracic and lumbar region. The core involves the multifidi, the longissimus, the distalis. If you palpate, just follow the 13th rib up on a dog, and you palpate that little corner on these older dogs that are creaky, you're going to find a lot of dogs that are really sensitive in that area. So palpating that outer regional muscle group, and then the iliopsoas, the sartorius in this case, and the quadratus femoris, that one part of the quads is one of those hip flexors. But the iliopsoas is one of the deeper muscles, hard to get to in a way, but considered to be extraordinarily influential. All the rehab classes talk about the importance of this muscle group. And it is anchored on the underside of the spine, last couple ribs and the first couple lumbar vertebrae. And if those are tight and you're extending the hip, that dog may respond painfully, not because the hip hurts. It might be because the muscle's tight and the muscle hurts. It might be because you're pulling, in fact, downward on there's a ventral force on the spine. So the iliopsoas is pretty important. And in the human side, they have a condition, it's called piriformis syndrome, where the piriformis muscle puts pressure on the sciatic nerve. And I wonder, this is kind of a funny view from the Budrest anatomy book, but this is the sacral articular surface here. This is the iliopsoas just under it, and that's the colon and the bladders down here. And if I zoom in a little bit, what's buried in the middle of the iliopsoas muscle is the femoral nerve. And I often wonder if you have a really tight iliopsoas, if that doesn't actually trigger some nerve-related pain associated with that relationship. So, am I going too fast? I'm trying to go pretty fast. Am I going too fast?
No.
Not too fast?
No.
Okay. You're doing pretty good. All right. So I look at the issue of what I'm trying to do to help support that joint. I'm very interested in weight control, omega-3s. Marlo referenced VASG. Let's see if I can do this kind of from a distance. So there are a lot of calculators on the VASG website. Excuse me, this is one of them. It allows you to, it includes a variety of doses. This is based on Bauer's AVMA publication at the end of 2011 about therapeutic use of fish oils in companion animals. But this one goes off to the right here, goes off the screen, and it has a variety of different options for omega-3 supplementation. Oh, this is the catch. This is what I still have to do. I still have to go back to that. We're trying to figure out how I could not stand in front of people. But the idea of omega-3s, this dose is far higher than any label dose you're going to see in any product. And that's the dose I aim for. So that's the key part, and that calculator helps you figure that out. So those are freely available on the VASG website. And Adequan, you know, we've had Adequan around for a long time. If applied early, I think it has a great potential benefit. I think the problem the mistake people make, my colleagues make, is that they'll use it later in arthritic disease. They'll expect a significant improvement in pain, reduction in pain. And when they don't see that, they think, well, it didn't work, so I'm not going to use it anymore. And I really think of it as a joint preservative more than an analgesic tool. So really important for me to get my patients started on Adequan early. And I mentioned Zydax. You might be aware of Pentasan above the border. The Canadians have had Pentasan, we've had Adequan. And Parnell they've been talking about getting a Pentasan product on the U.S. market in the not too distant future, so keep your eye out for that. And the idea of weight, a dog that's obese is not just putting more stress on their joints. The obese state creates a pro-inflammatory environment. These adipokines influence how fat is processed in the body. I'm not going to try and explain it in any fancy way. It is more than just excess weight on joints. It is a facilitator of the inflammatory process, obesity. So just another reason to try and get patient weight under control. And then I have quite a few different naturally derived agents that I like to incorporate. These are all really focused on trying to keep joints happier and healthier, especially earlier on. Desiquin Advanced. The advanced version is not inexpensive. It's pretty pricey. But it is a good product. If you go to the Nutramax website and look at all the versions of Cosequin now, your head can start to spin. You can't keep track. Cabela's has their version. And it's just all these different subtypes. So I like the ones that have ASU, avocado soy green tea. That's what ASU stands for. So that's why there's ASU and Desiquin. All right. And then the active lifestyle for dog and for people. This Cosamin ASU, that's what I take. I take the human version. And the active lifestyle has a boswellia component added. It's called AKBA. It's something phospholic acid. And then Glide is another Parnell product. It's got the green lip muscle, a lot of support for green lip muscles and joint support. My office manager does agility competition with her little Valhounds. Anybody have a Valhound here? I saw one in Chicago a couple weeks ago at a baby shower for our daughter. Little Swedish dogs kind of look like elk hounds shrunk down into corgi stature. Look them up; they're really cool. But she does agility with the dogs, and there aren't that many Valhounds in the country. I think up here there'd be a lot of, like a Valhound would appeal to people from this region. But the point is that Amanda, one of her dogs, is getting a little older and a little creakier, and she thinks the Glide has been very effective in reducing background chatter, sort of the aches and pains of her exuberance. So anyway, Glide products out there. Durlactin is milk-related. Go, mouse, go. Go. Got all kinds of battery, but for some reason it doesn't want to work consistently. Yeah, I'm going to have you get in this one. It is that. Oh, I'm sorry, no. It's the other one. You know, flip those around for me, if you wouldn't mind. Give you a little experience. Yeah, no. It hit just entered there for me. Give me a millisecond. I always travel with two of everything, including computers. Can you switch that? This one doesn't have a timer, but it's newer. Let's see. Huh. Oh, now we're done. All right, and then the idea of probiotics. Who here thought of probiotics as being part of the chronic pain management medication or recommendation list? There's a lot of literature on probiotics and chronic pain. This is going back to the same publication. It's actually the second half of that picture on obesity and other kinds. And they talk about the modification of the gut bacterial population leading to increased permeability, and it also adding to the pro-inflammatory environment. I happen to take a probiotic every day, and I think that it's not a bad idea in dogs that have chronic, and cats for that matter. And there are a variety of other natural products that, again, we talk to our clients about. You're not going to be on 50 things, although some people come in with a really big bag full of stuff, and they're trying to do 50 things. But the curcumin, it's in turmeric, probably familiar with that. But in particular, the Marivan, the Theracurmin, those are enhanced products that improve the absorption of the curcumin. And that's the key. If you did a PubMed search of curcumin in cancer, curcumin in pain, curcumin in osteoarthritis, you would be there all day long looking through the pages of publication. The kicker is, how do you get enough in the bloodstream? What's the right dose, and how do you get enough in the bloodstream? So curcumin, bromelain, pineapple extract, often partnered with, you'll often find a turmeric bromelain combination. Devil's Claw, Coriolis, Canalidin. The Veteran Science has their DemCore mobility. that has a combination, a proprietary combination of naturally derived agents. And this is a sheet we put together years ago. I send it to anybody that wants to see it. But it's the basic joint support from the earliest phase. And I always tell the client that the cores, the thing that holds us all together is weight control. And then I try and get them on adequate, I try and get them on the right dose of omega-3, and I try and get them on something naturally oriented as best I can. And I have become increasingly fond of pulsed electromagnetic field therapeutics. And they talked about it at Canine Rehab. They talked about the big machines that kind of the client had to come to you and kind of like look like MRIs. Some pretty expensive piece of equipment. And then there was a publication, I think this might be the one. It was late 2015. It was on the human side. I follow a lot of human medical. I get alerts every day on pain and anesthesia and things like that. And if it catches my eye, I follow it. And there was an article on a review, a fairly comprehensive review of PEMF and osteoarthritis. And it was impressive enough that I got a bunch of the CC loops, and I've been trying to get those in the hands of all of my clients here. And some of them, I think some of my staff are using them themselves. But I think there's a real potential. It's certainly safe. The idea of effectiveness, there are growing numbers of studies. They talk about the pain threshold increasing, so that's a good thing. After PEMF therapy of knee, and again, this is in people. But then this next study here was based on bovine cartilage. It's an in vitro, as I recall, study. But it had to do with PEMF preserving cartilage, helping to reduce damage at the cartilage level in the active inflammatory environment. So I really think that they're about $300 or so, right? And they last a long time. And I just think they have a real potential to be a non-medication, certainly completely safe tool, and best applied early. And I am a fan of the vet stem-based adipose-derived stem cell therapy. I'm still a bit undecided on the platelet-rich plasma, the CPET, VPET. If you have an interest in some of the articles reviewing the yield you get from the different options, give me a holler, and I'll send it to you. So I really focus on the stem cell-based therapy. Our corgi, our female corgi, we hope to have a litter of corgis. What's cuter than corgi puppies? Honestly, they're about as cute as they get. And so she's 2.5. We think it's time we get around to doing some pre-breeding exam work. And so she has mild hip dysplasia. That's not so good. We do the genetic test for DM, the genetic markers. She's double positive. So we're not going to have puppies. And when we spayed her, we collected fat, and we've done 3 stem cell therapies from about 3 years of age up through 11 now. And she still does not exhibit any sign of hip disease. She's since, in recent years, last 3 years, has had both knees operated for cruciate failure. So we'll see how she does. She's due for her 4th treatment anytime now. But the idea of intravenous and intra-articular applications, and even with DM, I'm toying with the idea of the next treatment for her, including an epidural or spinal component. They are exploring that at VetStem. They have been for some time for the DM patients. And then the idea that certainly pain medicine is a huge part of what we utilize. The non-steroidals. So who's using Galliprant already? Yeah. People generally positive impression. So we'll talk a little bit more about Galliprant specifically. I'm more interested in concepts than I am about the dose of Galliprant or why it's advantageous, except to say that there's no reason to think it isn't going to be a far safer non-steroidal. I've talked to a classmate of mine who's involved in clinical trials. Nobody should claim it should be a more effective non-steroidal. I think the orientation really should be that it's far safer by its theoretical development and by its clinical studies so far. We'll see what happens as we get hundreds and thousands of dogs on it, and some cats. So the PIP-print class, that's galaprint, or grapaprant. It's a PIP-print class. Surgically targets the EP4, the prostaglandin E2, EP4 receptor. And then the idea of COX-2 selective, you can find some inexpensive generics. So what galaprint is not is cheap. So if you're a big dog owner and you're looking at chronic use, it's going to be a burden. But the safety may be the key that allows you to use a non-steroidal. And I like to use an NMDA antagonist. We'll show you an article in a minute from Butch Kucinich, who does a lot of research on pain medicine. And some of the best evidence in veterinary medicine exists for amantadine's use in a multimodal analgesic combination. Some of the best evidence amongst all the different analgesics that we use. And then the reuptake inhibitors, tricyclics, and the SNRIs, that's Cymbalta, right? Duloxetine is Cymbalta, the generic name for Cymbalta. And it's a serotonin norepinephrine reuptake inhibitor. And that emphasis on the norepinephrine is what makes it more effective, it appears. So what's fascinating about Cymbalta is it's officially approved by the FDA, officially approved, for osteoarthritic pain, fibromyalgia, muscle pain, and for neuropathic pain. You see ads on TV, I'm sure, up here all the time for Cymbalta. And then the point is you can use any of these. Calcium channel blockers, gabapentin and pregabalin, and microglial inhibitors. We might touch a little more on those, but the microglial cells are huge in the propagation of central pain, the perpetuation of central pain. Janus kinase, that's Apoquel. If you do spend time on Vin and you read what Lester Mandelker writes, he's quite fascinated by Apoquel with regard to its potential as an analgesic. It works on the cytokines and interleukins. What is it? Interleukin 1, that's the itch pruritic target. The reason it blocks pruritus. But it also blocks interleukin 6, which is really important in the inflammatory pain process. And then NK1 antagonist, Serenia, is a lot of discussion about Serenia and its potential to reduce pain. We just don't know enough about dosing and frequency, and we certainly know that if you push Serenia pretty hard for enough days in a row, you're going to likely see some signs, some adverse signs, particularly in cats. But when I prescribe Serenia for a cat with chronic smoldering pancreatitis, I think it might reduce nausea, improve appetite, and reduce pain. I have that hope. And then I certainly consider rehabilitative therapy crucial with regard to osteoarthritic management. It is ideal to help keep the patient up and moving. The worst thing an osteoarthritic can do is grind you out. Absolutely. An underwater treadmill helping to support some of the weight. Boy, use the water to your advantage. It's a great tool to work with, but very expensive. And then the idea of myofascial trigger point therapy. In our coursework, there is no question that they think laser therapy can help reduce the activity of myofascial trigger points if you can get the energy to the trigger point, if you're actually bothering to find the other muscles that need to be lasered. But the idea of needle therapy, the leading training facility in the world for myofascial trigger point needle therapy or trigger point therapy in general, they all think that needle therapy is the most effective way to control myofascial trigger points. Has anybody attended Rick Well's course in Houston? Yeah.
I did some lectures from him, but not the Houston.
I highly recommend, I first recommend you take like the Chi Institute courses. I love the Chi Institute. But I really highly recommend you take Rick Well's course. he's connected to the Bethesda-based Milwaukee seminars people. Rick's the first veterinarian that completed that coursework and got certified. There's only been a handful. So Rick's taking the, the see one, do one, teach one, and he's taking that approach and he's trying to help spread the word. He's a great speaker to have if you haven't had him up here. So needle therapy is the most effective, but there's certainly, in my mind, the ability for gabapentin and pregabalin, the calcium channel blockers, and the Cymbalta or duloxetine potential to help with muscle pain, I think. So the short version, if I were to listen real quick, this is my little sheet where I'm trying to get everybody on this. If there's any hint of arthritis, so my Corgi had asymptomatic degenerative hip disease. There were degenerative changes there. So I started her on stem cell therapy because it was going to help improve the health of the joint. That's the theory anyway behind regenerative medicine. And I would include the Assisi loop. And again, I don't get any kickback from Assisi. They don't charge me any less. I wish. And then as you get into mild arthritis, where you might see some symptoms, I'd be doing all of this and both of those things if I was given the opportunity. And then I'm thinking we're probably only going to need intermittent NSAID use. Probably doesn't matter as much which one we use for both reasons. If it's more expensive, then it's probably not as big a deal with the client. And if we're not using it very often, then a less safe non-steroidal might not be a problem. But intermittent use, and I'm going to start paying more attention to the muscle status of the patient. And then this is just building. Now we have moderate osteoarthritis. We're always going to do these things. And now I'm going to expect to need more medication and to use a combination on an intermittent basis. And whether it's one of the non-steroidals with nicotine, I add one of these medicines. This is still a lower level challenge. I might consider acupuncture or needle therapy in some fashion. And then if we're pretty advanced, we're going to do everything. And the point is that you're likely going to need medication on a long-standing permanent basis. And then the question is, what's the least amount of medicine? I always develop a combination of medications. There's no magic formula. You can't say, well, exactly do this combination and start there and change to another. It's more of a concept of bringing a couple different medications into the mix. And then if things are going well, eventually phasing out the more expensive ones, the least safe ones. That's kind of how I look at it. So the question is, what's the least amount of medication? Minimum dose to best effect. And I'm going to expect to need some base therapy on a consistent basis. And then needle therapy, I just plan on it being something that I want to do if they gave me the chance. Minocycline, I mentioned the microglial cells. Minocycline, doxycycline, we get some pretty inexpensive generics around our area. So the idea that is a microglial cell inhibitor. If we got to the last slides, which we won't, I talk a little bit more about microglial cells, but just simply said, there's another list of medicines that if things aren't going well, you can say, wow, let's bring something else in. Let's add something else to the party. These are all different. They're targeting different structures, features, receptors, relays, different pieces of machinery in this complex chronic pain state. So Xylitine, some people think it's a cardiac medicine, but it's kind of the oral lidocaine. It's a sodium channel blocker. I've had some of my tougher pain cases on Xylitine. And there's a number of patterned after a number of human case reports and bits of literature that I found that led me to utilize it. And then I mentioned Apoquel, the JAK1, Serenia, the NK1 antagonists. There's lots of options. And if the joints are just totally wrecked, the consideration for corticosteroids. I don't use them unless the joints are wrecked. The idea of like 3 milligrams of triamcinolone with one of the hyaluronic acid products like polyglycan from Arthrodynamic. I know Rick Weil favors that combination. In botulinum, I actually tend to reach for Botox. I've injected a ton of joints, wrecked joints. I'll mention a study here in a second. And then the idea of replacement denervation. There's a study out of Germany years ago, and I've heard a lot of surgeons talk about some simple techniques where they've used IM pins to go in and just sort of scrape across the dorsal surface, the arc of the acetabulum, and just disrupt any soft tissue. The German study talked about denervating the hip and improving the patient function. And if you can do it relatively simply, I don't do it. I don't know anybody that does it personally in my area. But I think it's a neat idea, and certainly FHOs are out there, but they can be tough on certain patients, right? This is the Botox information. There's just a whole lot of human literature. People that aren't doing well, they've failed basic medication and intra-articular therapy. They aren't surgical candidates for a hip or knee replacement just yet. And consistently, you'll see 6 to 12 months, sometimes longer, improvements in function, reductions in pain, and improvement in function. And it's repeatable. So if it wears off and you're doing less well, you can inject again. It's a pretty attractive quality. You can get 50 units of Botox for around $400. So it's not a huge expense to get that in the door and consider a couple of intra-articular injections. I tend to do 25 units a joint. There are studies in print as high as 200 units injected into dogs for different reasons, not joints. Nobody's done a joint study. In fact, I think they're all prostate injections. And the idea that if you're not comfortable with intra-articular injection techniques, you go to the VetStem website, or if you go to the Arthrodynamic website, and they have a YouTube channel. And this long set of numbers and letters is just for you to draw out of your notes. But the Arthrodynamic has a really nice, very deep set of intra-articular injection tutorials. It's not hard, really. Unless the joints are arthritic, it's just hard to get in that kind of yard. And Arthrodynamic has this little table on injection volumes depending on the joint and the size of the patient. Just to throw it out there, it's easily found online. So I want to throw Reggie out here and get your thoughts. I love Goldens. Actually, I was waiting at the airport because our plane was in a mechanical. We had to wait for a new plane to be flown from Detroit to Buffalo to even start my trip here this morning. And there was a Golden that was a therapy dog walking amongst the people waiting at the gate. And I came over and I started chatting with him. I found him familiar, but I wasn't really sure who he was. And we got to talking a little bit more, and he said, I was at your place a year ago, and you helped me with my 15-year-old lab, Lexi. And this is her brother. We had to eventually put Lexi down. And this was her brother, Jake, that was the therapy dog, and that was one of the things he's done in retirement is doing things like that it was really a great opportunity. It was very calming. Jake was a perfect Golden. It reminded me of how great they are as a breed. But it also reminded me of how meaningful it was to this guy. He almost teared up talking about how important it was to him to have us help him and get as much as we could out of Lexi as she got older. But Reggie here was an 8-year-old Golden. He had a right foreleg lameness. It was becoming progressively worse. He was partial weight bearing. He featherweight on occasion. I'll show you a video in a second. We find really severe elbow disease, just got awful, munchy crunchy. We work through pain medicine and acupuncture and myofascial needle therapy, and we do rehab, and he improves, but he's still pretty lame. And I talked to the client, she thinks he's really happy, he wags his tail, he's happy as a dickens when they come home. Has a great appetite, Goldens usually do. And then this, let's see if I can do this from afar. This is Reg walking in, you can see he's still pretty sore. But he's getting in, he wants to use that leg. So, excuse me, anybody want to amputate that leg? Anybody think that's a good idea? How about euthanasia? Should we put that dog down if we can't make him feel better than that? We'll come back to it. All right, this neighbors of ours, I really like talking about Mackenzie because he's one of those cases that lived a lot longer than some people might have thought. But he was 11 years old at the time of this event. They were neighbors of ours, and they were vacationing in the Adirondacks of New York State. Beautiful area. So he had a lot of challenges. So he's 11 now. He had one knee at 5, the other knee at 10. He had a thyroid adenocarcinoma I took out at 9, so he's a couple years down the road. He's on daily and non-steroidals. He's on a reuptake inhibitor that could be amitriptyline, it could be duloxetine, it could be tramadol. Are y'all clear on tramadol not having really any significant opioid effect in dogs? That's why a lot of people have rationed down their use of that medication. That guy Kokanich I mentioned is the one that's done all the tramadol research. And he showed that in cats and people, we make a ton of opioid metabolite, is M1, M2. The metabolites in dogs are far different. It's just all the reuptake inhibition side. It's the monoamine reuptake inhibition, not unlike amitriptyline. So in dogs, it only really does one thing. But I like to talk in groups. It's less important which medicine in the group we're using. But on the 4th of July, I get the call from the husband. They'd gotten up that morning. Mackenzie couldn't even walk across the kitchen floor. They somehow carried her to the car. The missus was driving Mackenzie to our local emergency clinic in Buffalo, hours away. And he wanted to let me know. And it was clear, in my mind, I am absolutely sure that the dog would have been put to sleep if they got to the emergency clinic. Our emergency clinic in our area, especially at that time, was under different management, and they were not particularly sophisticated in how they looked at chronic pain. So I'm absolutely convinced that they would have put him down. The clients were expecting him to be put down. I didn't ask him that right away, but after he was doing better, we talked about it. He said, yeah, we pretty much thought that was it. They had young kids at the time. So I said, don't let her go there, let her, come drive her over to my house. So I took a look at him. He certainly had some really severe stifle pain. I went a little too quick. A lot of myofascial muscle pain and no signs of any neurologic component. So I called in some scripts, and we went from his basic non-steroidal and the reuptake inhibitor. We increased the dose of the reuptake inhibitor. We added amantadine, and we brought in gabapentin, the calcium channel blocker. A couple days later, he's a little bit better. He walked 20 feet. That's a lot better, 20 feet. And then we're 6 days out. He's halfway back to where he was. But we get a couple weeks out. He's not getting any better than that. He's stuck. So we get him in. We think maybe we do need to confirm what we believe to be true, that make sure we don't have cancer or any other disorder we should be specifically targeting. And we just find relatively typical findings for a 11-year-old Labrador with a lot of miles on the frame. So no surprises. We continue to develop his pain medicine. It's just a process of constant escalation. My upper dose limit for gabapentin is 200 milligrams per kilogram a day. And it's in your notes. And we have occasionally gotten there. And I've talked to Robin Downing. I hadn't gotten above about 120 or so. And I talked to Robin Downing, who's another past president of DAAPM. And I contacted her because Cornell was giving me a hard time about my dosing. I said, Robin, What do you think, 120 mg per kg per day, is that high? She said, I go as high as 200. So the point is that you have a lot of room with gabapentin. So we increased his gabapentin. We brought Adequan in. We initiated a twice-weekly rehab, comprehensive rehab therapy session sequence. And we get 6 weeks out. He's so happy now, he's grabbing the ball, wants to play. He's a lot happier guy. And the one key here I left out on the family was, I'll talk about loss in a minute, is the wife's father was in late-stage melanoma, battling melanoma disease and not doing well. And if they'd lost Mackenzie at the time that they were really on the cusp of losing their father, it would have been devastating. So to have him improve and do well was a huge relief. And in the end, he was lost to a GDV 17 months later, totally unrelated to the arthritic challenge. And if he got an emergency clinic, he'd been put to sleep. They were just like, this is awful, it's pathetic, he's doing so poorly, he's already on medicine, what else can we do? It just would have been Eeyore kinds of negativity, I know it. So, my backyard, the snow drifts. We get in Buffalo. Look at cancer pain. Have any of you had the pleasure of hearing Greg Ogilvy speak? I find it pretty energetic. I'm not sure if you thought he was energetic or not.
Say hallelujah.
Hallelujah. He's definitely evangelical oncologist. He's also a bicyclist. I see him over here. But I don't know an oncologist that has a more, a firmer dedication to the pain management of their patients than Greg. So all cancers are painful, some more than others. And anticipating pain, advocate for your patient. It's paramount that you factor pain into the process. So I'm just talking about bone cancer. I alluded to this loss reference. This study caught my eye quite a while ago, it was 2007, in the AMA journal. And it was a review of grief-related issues and the impact, the difference between having a terminal diagnosis pronounced and losing a family member in a short proximity. It's so much harder on the individual if you have somebody lost shortly after they're diagnosed with a terminal illness. So I think I said that right. So it makes a lot of difference if they have even 6 months to come to grips with the pending loss. And I sort of can appreciate that from the losses I've had with my Goldens, one at 6, one at 6 or 5.5, both to cancer. So the idea that grief persisted longer if the death occurred in short proximity. And they're much more likely to have this prolonged grief disorder, even 2 years later. So if you can buy 6 months of quality, decent quality time for your cancer challenged patients, that can make a world of difference to a client. That's my point. So bone cancer facts, just the quick summary, and it's close. There are a lot of different numbers you'll see depending on what you look at. But the bottom line is you typically have about 90% of the patients already have mets, and that you can almost never see them, right? So they're there, the micro-mets, but you can't see them. So if you can't see them, you're not sure, is this the 1 in 10 dog that I might cure with an amputation, or is this a 90% dog that already has it and they're just waiting? Amputation does not reduce the frequency of metastasis, right? It doesn't make things metastasize. But what it does here, this is interesting. It was came up on a discussion on VIN, something I've pursued ever since. Amputation has the potential to accelerate metastatic disease. So we'll come back to that. Median survival with pain meds, it's not a pretty picture. These are the statistics that are often quoted. You look on VIN, you see different numbers. It's not very long. Survival with radiation therapy, just palliative pain therapy, right? Fairly expensive, 2 2 to 4 months, not that long. Median survival with amputation alone, 2, 3, 4, 5 months maybe. 10% alive in a year, well, we knew that because 10% didn't have meds. And then only 2% are alive in 2 years, so I don't know what happens there. Maybe they just fall old and they just don't do well after a while. Median survival with amputation followed by chemo. I see numbers typically in the 8 to 12 month range. Some studies you can see a little higher. 40% alive in a year, 20% alive in 2. That's better. Median survival with effective multimodal pain therapy. What if we did really good pain therapy and we did use chemotherapy? Help control the mets. What is amputation aimed at? Pain control. That's it. That's all. So if we control pain effectively, then why not leave the leg, control the pain, and still use chemo? Try and help suppress cancer-related progression. Nobody's done that. So I know I had this perspective. I could think in the past, easily think in the past, cases where we find evidence of osteosarcoma, and we're pretty much telling the client, if we're not going to amputate, it's not going to be long. You're going to have to start planning. Really had an amputation or euthanasia mindset. I'm trying to get people to rethink that. So the consideration for amputation, when might that seem like it's a really good idea? Certainly the thoughts center around chance of cure. You happen to be the 1 in 10 dogs, or you're a cat, right? You expect to cure a cat with the amputation. So cats, we're talking dogs, except for that comment on cats. All right. So if you have complete disuse, and you really think that leg is inhibiting the patient, and they don't mind spending money on the amputation, they're going to weigh less, maybe they'll get around better. That's a consideration. Certainly if I have unrelenting pain, you got to do something. And then the idea of pathologic fractures. My opinion on that, I put question marks there. We're going to talk about Gus. Arguments against amputation. It's not cheap, especially if you do epidurals and analgesic CRIs, and you're really covering all the elements that make it really ideal. The surgery is costly and the chemotherapy is costly. And you got to do chemotherapy, right? That's the only way you can control those mets now that you've taken the primary away. The idea of general surgical complications, it's not a small surgery and it can lead to complications, including the risk of chronic post-surgical pain, phantom sensations. Not a cakewalk, it's a surgery. And you do lose metastatic suppression. Angiostatin and endostatin are the 2 components that are not poorly understood. They're an interesting phenomena that is not it hasn't been discussed in much detail, is how I would describe it, but there's a lot of literature behind those 2 elements. And the thought is that there are so many dogs that just can't function as a tripod. And if you don't think carefully about how the patient might do with 3 legs, I think a lot of dogs end up being put to sleep after an amputation because they look so pathetic as an amputee, and it wasn't well thought out. They weren't properly supported. So this is just a couple slides because it's a short version, but the idea that in cancer patients, dormant micromets, often asymptomatic and clinically undetectable for months or years, and that these rapidly grow and the inhibition of angiogenesis is removed. And then this is an animal study specifically talking about dogs. Angiostatin fragments are present in the urine of dogs with bone cancer. And that, importantly, these fragments are absent in the urine collected after complete removal of the leg. So you pretty much have to do chemotherapy, otherwise those micromets are going to come raging back. And there is an argument, there is an advantage to leaving the primary if you can control the pain. So cancer pain, not unlike neuropathic pain, and it's never just cancer pain. You have to look at how the rest of the patient's responding to their disease and try and help all the problems you can. if you help the other 3 legs to function much better than they were the last couple of years, that patient's going to cope with the bad leg in whatever form you manage it a lot better than if all you do is cut the leg off. So what we do at cancer therapies, if I have a case come in tomorrow, I just assume admit them for the day, run an analgesic CRI, fentanyl, lidocaine, ketamine as a base, utilize an epidural under sedation. We'll do a local block, do epidurals under sedation. We're sedating them for radiographs. Usually that's all part and parcel to the day visit. And bisphosphonates, pembedronate is the one I use. Zoledronate is the other one that's much more expensive. But this is not an expensive agent, and bisphosphonates can be huge advantages in your cancer pain management process. This is the therapeutic sequence. It's in your notes. The dogs and cats, about the same dose, 1 to 2, 1 to 1.5 mg per kg every 3 or 4 weeks. It's given as an infusion because if you give it rapidly, it can be hard on the kidneys. So you dilute it in saline and you give it over 2 hours, less for a cat, more for a dog. So it's not expensive, it's not complicated to administer, and you can repeat it every 3 to 4 weeks. It certainly has the capability of decreasing pain. It inhibits the osteoclastic cell activity, and it can be directly analgesic. Louis Philippe Delormer, I'll quote him in a minute. We were chatting the other day, but he has quoted on VIN that about 50% of the cases in his hands have had a significant reduction in pain just from pamidronate alone. We always do things in combination, so I can't really tell what's doing what. But you inhibit the osteoclastic activity. Having trouble with new mouse. It decreases pain. It has an anti-angiogenic effect, so it does actually have some potential to inhibit the disease. And it certainly has the ability to reduce stress fracture risk. It can help stabilize the bone. If you get right on bisphosphonates at the beginning, early detection, early signs, early changes at the bone level, not like Brutus where it was Swiss cheese and not even very substantial Swiss cheese, it can make a world of difference. And then the idea that there's some renal stress, but I've never seen it create a complication. And honestly, if you're fighting bone cancer, are you really worried about the kidneys next year or the year after? Not so much. So the priority is controlling pain and controlling disease, and I've not yet seen any kidney-related adverse effect. I'm going to use all these medications. Pick one of the reuptake inhibitors. And I don't have tramadol on here because based on Kokanich's work, you got to give it 4 to 6 times a day to actually have decent therapeutic blood levels. Whereas I can give amitriptyline or duloxetine twice a day, and that's a normal dosing for those medications. So I use one of these two, calcium channel blockers. I use gabapentin because it's cheaper than pregabalin. And then amantadine. We use a ton of amantadine. Use it on almost every case. And I use a non-steroidal, but I don't really think they're that effective for pain management. But the non-steroidals have the potential to exert additional anti-angiogenic effects, so they can help slow the disease down. So some people argue for Proxicam. I know Greg Ogilvie just keeps talking about how there's just so much more experience with that particular non-steroidal. But there's a lot of support for Meloxicam and Carprofen. And there's a lot of interesting literature out there and discussion regarding Galaprint, the EP4 non-steroidal, and its cancer suppressant potential. So I think there'll be more, in the future, more discussion regarding that aspect of Galaprint's use. The non-steroidals can help slow the cancer down, but in my experience lately, I've tended to start with a corticosteroid run, and I've found more consistent. I think on average, we're getting better initial responses and a more rapid control of the patient pain when I start with cortisones. There's a lot of human stuff, a lot of human discussions regarding that. So I've shifted over, in most cases, if they come in on a non-steroidal, I might stay on it. And I never switch right away. I'd always want to wash out at least 3 days if I was switching. But if they're not on one of those, I'll probably start a corticosteroid, prednisone. And then when things are under control pain-wise, I'll phase them off the corticosteroid if they're still doing well and switch to a non-steroidal for the cancer suppressant side. So I do all those things. And getting back to matrix metalloproteinases, the MMPs, they're part of the inflammatory process in arthritic joints. That's where Adequan exerts some of its benefit, that disease-modifying metalloproteinase suppressant side of Adequan. But there's an aspect of MMPs, metalloproteinases, an aspect of their involvement with the breakdown of the extracellular matrix in bone cancer, and that promotes tumor growth. And the inhibition of the process should be a consideration as targeted therapy. And there are some mouse-based studies, models, having to do with breast cancer that's metastasized to bone, and that the MMP inhibition has significant benefit for those patients. So I do think there's some real reason, there's a real potential for doxycycline and minocycline to help. Those are the MMP inhibitors that are talked about with osteosarcoma or bone cancer related, either as primary or metastatic. So I think that's another tool to consider. I just categorically avoid opioids. I don't use opioids for any of my chronic pain management patients, period. I just don't. So these are some of the reasons I don't use them in cancer. If you look hard at what opioids can do that you don't want, it's not hard to find. Potential to facilitate cancer growth, potential to cause immunosuppression. Opioid tolerance. The simple fact is people that are on long-term opioid therapy have to rotate. You don't just stay on the same medicine forever. Doses have to escalate. You have to rotate from one to another to try and get around this tolerance issue. They become less and less effective over time. That just makes them hard. So using the same one constantly is fraught with expected eventual just discontinuation benefit. You just expect less and less of it. The idea of opioid-induced hyperalgesia, I've seen that. Opioids can enhance pain, and it can happen within a few days of utilization. It doesn't have to be long-term. And there's certainly a lot of regulatory headaches. All right, too fast? Going too fast? I know we're getting towards the end of the time here. Let's see how we're doing. You want me to go on?
Yeah.
All right. Anybody got a tie on? And I think it's crucial. It's so often I see somebody come in after having a really nice lymphoma protocol play out at a referral practice, and then nobody's talked to them about diet or other cancer suppressant simple things that just make sense for any of my cancer patients. So low carb diet, it's not rocket science. I mean, there's commercial diets out there, and Ogilvy is his recipe. I think it makes really good sense to get them off regular dog food. There are some commercial options, a variety of different options. Ogilvy's huge on DHA. If you've heard him speak about DHA, or you search his publications, things that are out there on the internet, not hard to find his DHA support. And there's a couple different dosings. One's based on weight and one's on the body surface area kind of deal. And I'll just prove that one of the things we do have is one that's a calculator specific to, oh, this is hard from here. Calculator specific to DHA and cancer suppression alone. It calculates the two different ways, and you can decide just how you want to dose things. So I have everybody start a DHA supplement, and curcumin, melatonin, herbal therapeutics. Anybody use Jingtong Herbal Therapeutics here from Dr. Shea's outfit in Florida? So stasis breaker, weight sheet booster, bone stasis, variety of anti-cancer herbals. And the clients feel better when you're doing something as opposed to just saying, well, this isn't great, it's going to get worse, it's going to hurt more, the light's probably going to break, and you probably should just plan to put them down soon. So there's a lot of little things that they're doing, and they get engaged in the supportive process. That's just my sheet that we send our cancer patients home with. Just fill in what I want them to do. And touching on curcumin, it's amazing. It really is amazing stuff. With the idea of it being a chemosensitizer, helping to improve the response to chemotherapy, the response to radiation therapy, and to help guard other organ systems that aren't involved with the disease that might otherwise take a beating from the chemotherapy or the radiation therapy. So I think there's a lot of potential benefit there. And going back to the short notes here, I want all of my cancer patients to be on some sort of diets the bottom part here, some commercial diets listed. We send them over a couple recipes if they want to cook. DHA's this section here. So we all, just kind of like the arthritis thing, these are simple things, they're not expensive, they're more naturally oriented. That's a foundation. And then we're going to, every chance I get, pamidronate, I'd like to admit them, as I mentioned to you, do a CRI and epidural. And that's just, I could bring up an analgesic CRI calculator and just show you how those look. But I'm not going to use that time right now. We could look later if you want. In oral therapy, it's all these guys. Reuptake inhibitor, calcium channel blocker, NMDA antagonist, as I've alluded to, an NSAID, and this microglial MMP inhibitor. I actually don't have prednisone or cortisone on this listing, do I? And the HER2 vaccine, anybody heard of that? It's not an oncologist. This is pretty good stuff. The question, I can't find any indication of when it's going to be practically available to us. Just like Galliprant was supposed to come out, things take a long time. But amputation, chemo, and vaccine, I kind of did this backwards after I looked at it. But with the vaccine included, this median survival is 960 days. As opposed to the non-vaccination group, just chemo and amputation. In this particular comparative, they got 400 days out of amputation and chemo. They more than doubled that with that vaccine. It's a listeria derivative. There's certain tumors that have this HER2 feature, and this vaccine triggers an immune response, and then you go attack that tumor. So I don't know when we're going to see it, but Advaxis licensed this, or at least is working with Aratana, and Aratana is the Galliprant people. They also have that Entice appetite stimulant coming out too. They do some pretty cool stuff, clearly. So, and then rehab. Just because they have cancer doesn't mean you can't work on all the things that might help the dog that's having trouble getting around. So rehab, home exercise program, look at the home environment, what do they need, ramps and help them ups and things, and needle therapy can help. Whether you believe the cancer suppressant side of acupuncture, which is part of what you're taught, or you just think it'll help with pain relief because you know that's probably the best thing you can do. It's definitely capable. And so this is Gus. I said I wanted to talk about Gus, pretty cool case. A 12-year-old female spay. She sustains a convoluted right femoral fracture, really severely convoluted right femoral fracture. While on a leash walk on July 4th. Everything happens on July 4th. So don't take your dog on walks that day. The local emergency 24/7 facility does chest rads. They do see a pulmonary mass. And so just in the back of your mind, what's the prognosis for Gus here? With surgery, I kind of think you got to do some surgery. And then without surgery, I don't think there's any future without surgery. So let's take a look at Gus. 3 months post-op. See how well she starts out. Notice anything surprising? She's got 4 legs. Can you tell which leg's the fracture? Osteosarcoma leg? I don't think you can. So she has a pathologic fracture. Jim Fingeroff, surgeon in our area, did an amazing job putting this back together. We initiated cancer support. She was our client normally. A couple weeks later in August. And we brought the non-steroidal in. She wasn't overly painful. We didn't use cortisone. She was coming out of surgery. I'm sorry. Keep pushing the wrong button here. So on the carprofen, we initiated the DHA supplementation, melatonin, and low-carb diet. We initiated pimidinate right away. And from July last year, or August, I should say, through February, she's had 6 treatments, so close to every month. She's the osteosarcoma patient we've had engaged in the most consistent use of pimidinate. So she's had 6 pimidinate infusions. She's on herbal therapy. Pain medicine arguably might be carprofen a little bit. The gabapentin for sure, and the pimidinate certainly is contributing. But we're not using a ton of pain medicine. And I talked to LP, Luis Felipe de Lormer, the oncologist, about this. I said, hey, what's your experience with pimidinate with dogs with pathologic fractures? And this is what he said. He said that they've seen many dogs, including these study dogs with pathologic fractures, eventually repaired and develop solid calluses. I do have progress films of her if you're curious. I'm not going to show them for time's sake. But simply said, Luis Felipe is a huge proponent of pimidinate with a pathologic fracture that's been repaired. So I never really thought much about taking that avenue of considering a fracture repair. I kind of had a frame of mind that was already fractured, I probably should pull the leg. But Gus changed my mind. This is Gus. Just a couple weeks ago, I asked him for video, and they were thrilled to send me this. So she's 8 months out, going on 9. You see she kind of trots here in a second. She's got a nice little bounce on her step. She likes having 4 legs. She's 8 months out, going on 9, and she feels great. I don't know how many people in this room really thought there'd be that many dogs that could do that. They said, I have to say this to Dr. Stein because it made us laugh. That's her young brother Murphy, but then that's Gus. She's like, what the? So you don't think that family loves the fact that she's doing that now 8 months later? Pretty big deal. Actual reality is she was on the walk, she was jumping up against somebody that was coming across the sidewalk, and they kind of tugged her back. She fell and broke her leg, and they felt so guilty. They felt awful. And now they've had this 8 months, and there's really no end in sight. They're going to be okay with their loss. Sad, but okay in a way they wouldn't have been last year. So we're back to Reggie. So Reggie really was a bone cancer patient, right? He was a distal radial osteosarcoma. And you could see that he used the leg, but he didn't use it all that well. And the client said, yeah, he's happy. You can see him wobbling up front because the golden legs are all behind. And he's over here chowing down with his buddy, happy as a clam. So he's not walking as normally as Gus is, but I don't know. I've seen a lot of arthritic dogs that didn't walk much better than that. And when you start out thinking, well, just because I tell you it's osteoarthritis, you don't think we should amputate, but then if I tell you that it's osteosarcoma, then most people immediately jump to what the oncologists say, which is you got to amputate to keep. So he did better. He was happy. And then we lost them about 9 months later. And typically in these cases, they have an acute decline. They don't just phase out over 9 months. They do really well, and then everything goes down, pretty much. And a couple quick ones. So 12-year-old Golden comes in, a progressive worsening left hind leg lameness. You get these films out of the processor. What do you think? Is he going to be around for a while? The clients are not going to amputate this dog. Absolutely not. So this guy Aspen, I usually talk about him end to end, but Gus is now my favorite case. This was kind of my favorite case before. He had bilateral hind leg hip and stifle challenges. His right foreleg, significant enough orthopedic disease that he had serious atrophy of his scapular muscle mass. So he had 3 bad legs, and then his left hind leg develops that distal femoral obvious neoplastic disease. The clients are not going to amputate, even though the wife's sister was a head tech at one of the local practices and begged them to amputate. He couldn't have functioned as a tripod, especially not without really good pain management for everything else. But in our hands, about a month later, I got the email from the client. He hasn't walked this well in years, running better than the owner. So little Aspen, 18 months later, the bottom fell out for him. There are a lot of patients. Mocha, biggest dog. This guy's a moose. This is him with his raccoon he caught out in the back woods. But he came in, our local, one of our surgeons in the area, had seen the dog, took the radiograph, said it's a neoplastic disorder. We can biopsy it and try and prove it. Client's like, no, I'm not going to do that. And not remotely interested in the amputation. This dog is really wickedly lame. He has proximal humeral disease. We use the combination of medications I talked about, including the cancer suppressant therapy. He lived 22 months. And he did really well. There was a point about 8 or 9 months into this where he said, Doc, I don't think he ever had cancer. I said, well, let's take a look. Let's take some more films and see what we got going on. And there was quite significant progression of the disease, but the pace was decidedly benign for a bone cancer-related disease. When bone cancer wants to be bad, I mean, you can say that about any cancer, right? And if cancer wants to really be the angry version of that particular tumor type, you're in trouble. So I don't think it's amputation or euthanasia. I think you really need to be very thoughtful about whether they can function on 3 legs. And I think you should consider really well-developed multimodal pain therapy before you consider amputation, because what do you got to lose? And reserve amputation for really unrelenting, unbearable pain. And that can happen. And that when you do amputate a leg, I highly recommend you use epidurals and analgesic CRIs, even 4-leg amputations. If you use 0.3 mLs per kg of total volume, and you just stick with morphine and saline, and you inject slowly with the bevel facing forward, most people, most anesthetists think you can affect the front end of the dog and exert a positive influence for an 4-leg amputation patient. So we always do a epidural. And a complete nerve block. I used to fret about, do you inject around the nerve, do you inject in the nerve? And then you really dig into the literature. We talked about this on the Venom a while back. You really dig into the literature. It's like, the only thing I care about now is making sure there is no twitch when I cut through a major nerve. And I do not mind injecting into the nerve. So I'll leave it at that. And then the idea of extended multimodal pain therapy after an amputation, thinking there might be phantom pain at risk. And then still this anti-cancer supportive approach. So I'm guessing it's 9 o'clock or a little after. Hey, it's 9 o'clock. Wow. I figured I'd get to this point, and I kind of thought I'd be lucky if I did. So the next section gets, this is my reminder that our patients aren't all, round pegs and round holes. There are some oddballs. So you gotta, just remind you can't just do the same thing for everybody or think that you can't occasionally, that you don't have to occasionally mix things up. So the next thing is just about pain medicine. If you wanted to talk about Galliprant a little bit, we could. I could just talk about questions if you want, or we could just stop. Okay. It's up to y'all. Keep going. Want to look at something? I mean, y'all can, obviously you can leave whatever you want. And I won't feel bad. So there's a question. Certainly any questions.
With the gabapentin, some side effects is anxiety. Do you have any recommendations?
Is the question whether or not I see anxiety when I use gabapentin in my patients?
Yes.
I do not. I do not. I expect sleepiness, somnolence as they call it on the human side. I expect a sedating, sleepy quality. If the clients complain to me, they complain to me about that. He seems so sleepy, I stopped it. Even though our paperwork says, make sure you call us before you change it. So I don't see anxiety with gabapentin. I've been on gabapentin for probably 10 years. And I don't have any more anxiety than I already had before that. And I think it's made a huge difference in my lower back pain. Huge. I sleep better at night. Oxycodone. Question is regarding a very powerful opioid agonist. I don't. And if you look at Butch Kucinich, let me do this while we're chatting. I'll go right there. If you want to read one really useful summary, go to the Veterinary Clinics in North America, September 2013, and read Kucinich's review of oral analgesics. And he does talk about codeine, OxyContin, hydrocodone. What else am I missing? But he talks about oral opioid use. And he makes it hard to be optimistic about how we should dose them, how frequently, how much. He doesn't recommend them, any of them. So I already alluded to the fact that if you stay on long-term opioids, you're going to get tolerance. You are going to get tolerance. That's not if you get tolerance, you rotate opioids. In human chronic opioid therapy, it's a question of when are you going to start rotating. So if you just stick with the same medicine long-term, it can't work as well over time. So it is highly divertible. It is highly abusable. I don't like the fact that it can cause increased pain, that it has a variety of negative potential impactors. But Kucinich, read that and make a decision for yourself. I've decided not to use opioids in my chronic pain therapy. It's not like I had a bad experience, and like ever since then I don't use them. I just, as I look at all the literature, I'm like, I don't need to, actually. So I use a ton of opioids perioperatively, but not chronically as outpatient therapy. Yes?
How are you using amantadine? Are you doing it long-term, or are you doing pulsing to ramp down, ramp up, or how are you?
Question about amantadine therapy, and am I consistent, or do we do pulse therapy? And I start out consistent. I really prefer 2 to 3 milligrams per kilogram twice a day. And I do think that might actually go back to Kucinich even. I started out using it 3 to 5 once daily. That's how most people see it listed. I think it works better at 2 to 3 mg per kg twice a day. So I start there. And then this concept is I add things and I add things and I increase dose. If I don't think they're tolerating something, I swap it out. And I have a goal of good patient response. And if I get there, they're doing well, then I look at what I'm on, what's expensive, what has adverse effects. If they're on a COX-2 non-steroidal, that's the first drug I want them off because of the safety side. Galliprant's taken that away from me, although I still need to see it remain fairly safe. And then I look at what's expensive, and amantadine's become so much more expensive. I used to buy 100 for $25, and now it's $180 or $200. So it's not cheap. So then I'll be like, well, they're doing well. I don't mind stopping it. I don't mind stopping and starting a Mantonine. If I stop it, they do as well. They stay off for a while. If they're not doing as well, I'll bring it back in. I don't have like a fixed plan. It's going to be 2 weeks off, 2 weeks on. I just see how things flow out. Yeah.
What's your max dose for gabapentin for cats?
As much as I can get into a cat. Honestly, right? How much can you get into a cat to begin with? I think gabapentin is listed in this part of the notes, and you'll see this stuff. I find cats are much more likely to take gabapentin mixed in their food than they will amantadine or tramadol or any of those other things. So meloxicam will take that, but we have the black box. Onsero will probably take that. Gabapentin, it's pretty surprising how many cats accept it. And if you've tasted it, it does not taste neutral. I taste most things to see what the patient's up against. But I think it's just literally a point. The deal with gabapentin, and you have to kind of jump through to the slide, but we're going to get into galliprant. The deal is gabapentin has nonlinear pharmacokinetics. So that means, in its case, that as the dose goes up, you actually absorb less. There's a point at which you just don't absorb anymore. So it just flattens out. And so when you think about these really high doses in dogs, because you might be able to get a dog to take 200 mg per kg a day, there's a point at which you're just wasting money. The extra gabapentin is going out in the trash. So I typically start at 5 or so mg per kg in a cat twice daily, and then see if I can ease up towards 10. I don't have a limit so much as I just think there's a point at which if I try and go higher, they're going to stop taking it.
I find they get really wobbly if you get too high.
Well, the dose, it's the duration. It's the same thing in people, same thing in a lot of patients. You can start high and we'll all be wobbly.
Right.
And so if you start low enough, you move up slowly enough, most patients aren't going to be that wobbly. But you could still have a patient that is going to be, and then that's an additional factor. But it's not like safety. It's not like you're going to get X and it's bad and they're going to be dead. That's not the talking point for gabapentin.
So do you compound yours then, or for those really high doses with the dogs?
On the dog side?
Didn't you say, wasn't it the gabapentin you go up to 200 mg per kg?
Yeah. No, it comes in 600 milligram tabs. They're really cost effective. So you might think about compounding on a cat, but I typically don't. I have them take the 100 milligram capsule, cut one half and have it fall into a little dish, and then just twirl out the other half into the food. That's as close as you need to be, and then mix it thoroughly. So I don't bother to compound it in the cat if they'll take it that way.
Can you comment on your strategy usually with cats with chronic osteoarthritis?
Well, it'd be pretty similar. So the question is the cats in chronic osteoarthritic pain. You just start out from, like omega-3s, Adequan, weight control. That's all good. Then if you were to look at the naturally derived agents, well, there's Cosequin for cats and some of those derivatives for cats. So what can you get a cat to take that's in the naturally derived camp? Well, you just got to start out with a cat and say, how many things am I going to get into this cat? Period. There's a whole page on the VSG website of everybody's ideas collectively of how you can deliver oral medications to cats because it's so difficult. So you could use naturally derived agents. The non-steroidal might be the talking point where you say, well, I try and avoid them. I'd rather do needle therapy, gabapentin, work on the omega-3s, get the Adequan going. I think cats tolerate cortisones relatively well, and that sometimes has a significant sustained effect. And then if you're looking at non-steroidals, the meloxicam side of things kind of makes us think we shouldn't do that with black box. Onseor's got some really good long-term studies. It's buried in here. That's galliprant stuff. Not too far away. So galliprant, just to touch on that while I'm on this slide, the studies are already, they've at least started the feline-related studies, gabapentin. These are pretty high doses, upwards of 15 mg per kg, 28 days, no problems. So I definitely think I'll be exploring that medication because we don't have anything labeled for chronic use. So you can use robenacoxib, which does have some really good, twice daily 10 mg per kg dosing for 42 days, no detectable toxicity in healthy cats. That's pretty comforting. And then you've got the robenacoxib now in cats with chronic kidney disease. No clinical indication of damage to any organ system. They didn't worsen in this study. This is one of the King studies. I guess it's both King studies. So I'd pick Ensure as an option, even if they had a renal component, because that question comes up on VIN all the time. If the cat isn't better pain-wise, they're not going to go on. So it doesn't matter if it's going to be long-term toxic to the kidney so much. There's an immediacy to the cat's pain. So I don't know if I'd start with robenacoxib or galaprint today, now that I have galaprint in my building. But those are considerations on the cat side. Acupuncture, a lot of cats will tolerate acupuncture. I think, and some cats are getting the underwater treadmill, and you can laser them and whatever. So a lot of options for cats. Any other questions? Yes.
For the, or folks with, I guess, financial issues, would be, I guess, your top choices, especially for small dogs where it seems we're a little bit more limited.
So the question had to do with the economics. What's the most economical approach to chronic arthritic pain? If we're sticking with that quite specifically. Well, there are a lot of pretty inexpensive generic non-steroidals now, right? So if you're not stuck with Rimadyl or Previcox or Duramax, if you're not stuck on one of those guys, or branded Meloxicam liquids, there's generics out there now. They're pretty inexpensive. So I think you can get into a non-steroidal pretty inexpensively. The omega-3s, a lot of those products are certainly not expensive. Gabapentin is not expensive. It is super cheap. And that's one of the reasons why I have a fondness for trying it whenever I can, because if it doesn't work, fine. But if it does, it's got the cost advantage. Very inexpensive. And the potential, once you get a patient doing well, it's not unusual to get gabapentin blocked back down to once a day, or certainly much lower doses. But I'm not sure quite how to answer that, except to say I have a cost calculator on the VAST website where you can input things and look at some costs. And I'm starting to toy with a non-steroidal specific addition to that, which I haven't completed. Yep.
The rationale for melatonin, what does it do?
The question had to do with melatonin because it popped up there. I was thinking about should I say something or not. If you look at melatonin and pain, you do a PubMed search. Do y'all know you can create an account on PubMed? So I have my RMS DVM account. And then I do a search, and it's melatonin and pain. And then the results come up, and at the top there's Save Search. And then I save the search. And it gives you the option of getting an email that lists how many studies have come out in the last week on melatonin and pain. And do I want them every day? Do I want them once a month? I've got probably 300 or 400 saved searches having to do with pain and anesthesia. And so I'm constantly getting emails from PubMed. And I open it up, it's an author, like Clifford Wolf, the guy that proved there's central sensitization. Whenever he writes something, I take a peek. So you can do it by author, you can do it by subject, medication to pain, medication to cancer. So if you do melatonin, you'll see a lot of medical literature regarding its potential to reduce pain. It was discussed in my Chi Institute herbal therapeutic side of the traditional Chinese patient management approach as anti-cancer. And there's some elements you'll see in the literature on that too. So it's simple, inexpensive. Some of these patients in pain, it's a fact that if you have chronic pain, you sleep poorly. If you sleep poorly, your chronic pain is much harder to manage. It's a vicious cycle. And so sometimes I do have them give it at night. Sometimes I think it might help settle the patient later in the day, get them to sleep better. So there's multiple factors. Because it's so inexpensive and simple, it's once a day. It earned a spot on my list. No more complicated than that. Question?
So for these really big dogs that are on the Lindenade and the, they're doing everything,
Yeah.
average cost per month?
Well, I alluded to that 90 milligrams of pimidronate, that the dose range is 1 to 2 mg per kg. And so you could argue you could treat a 90 kilogram dog. And I've seen some. We had a Mastiff came in, he weighed 240 pounds. And he was not nice. But I don't see many dogs that big. So the drug pimidronate is not a big expense. To run an infusion for a couple hours in our practice isn't that expensive. I mean, it's a couple $100. The gabapentin, again, you'd have to actually pull up the calculators and we could do it. The gabapentin is not expensive. The cost-effective sizes in my area from my distributors, 300 milligram capsules and 600 milligram tabs. The hundreds aren't expensive just because they're hundreds, but they're still more expensive per milligram than what you get in 300 caps and 600 tabs. So I'll leave it at that. None of those are expensive. And not that many, most of my bone cancer patients get a pimidronate or two, or now and then, that big dog Mocha that weighed 130 or so pounds, that big Great Dane mix. He had a handful scattered over his 22 months. He'd just do it here and there. We try and get him to do it every month, but we don't have a lot of high-paying customers. Any other question?
You heard about anything about vitamin B17?
Vitamin B17 specific in a pain management setting. It's not on my radar. I got a big radar, and I'm well aware that there are a million things that are not on my radar. You just can't keep track of, after a certain point. And you can't, it's hard to talk to your client about 50 options. You kind of got to end up with your subset of things. So if you email me and you give me some good, links to material, I might put that on my radar. But I don't. Your experience is it can be beneficial?
This is anti-cancer.
Yeah, and there are so many things out there that have potential. Dose, absorption, plasma levels, there's so much we need to learn, but it's clear there are a lot of things that drug companies may not be developing that might still be options. Other questions?
The future, like cannabis use with severe chronic pain, pushing the cancer dog was happening.
Will I get there in time? Wisconsin's red. It says you can't do it. It's not red because of Wisconsin. No, honestly, you can't do it here, right? I didn't think you had any medical wiggle room whatsoever, legally. Really? Like CBD oil specifically, if that's the deal?
Seizure issues.
Yeah.
Probably stretch that.
So the question was about cannabinoids, as I prefer to say, in the CBD oils or derivatives. I was talking to a friend of mine that a group in California is a water-soluble, really high-purity CBD product that they're able to produce. If we can standardize the amount in a whatever ml or gram or whatever, the support for the cannabinoid utilization within seizures and pain management, there's no shortage of optimism with regard to the potential. And then in New York State, we have medical marijuana as a legal option, but when we called our state society not too long ago, they said, especially with the new administration and Sessions and control, that they said, you know what, we really recommend you don't. And I got a really, really refractory seizure, epileptic shepherd that I want to use it on. So RX Vitamins sells their product, and I just don't know how you can get it to somebody in a state where legal aspect starts to work its way in. But you have to go to those RX Vitamins, and some of the products that are out there, I could send them to you, I can't remember the other names. But because I can't really use them on just a free basis, I just haven't, it's not high in my consciousness. But you look at those products and they give some doses and you're like, okay, what? I mean, you could try it. So I think they're really pretty safe, and I think they have great potential. And the human medications that are the Deluxetine version, the Cymbalta-like branded expensive medicine version of the cannabinoids, super expensive, super duper expensive. So I hope that we end up not too far down the road. There was just something in nightly news in the last night or two about the elderly and chronic pain and cannabis capsule-oriented, some version of it. It's crazy that it's still Schedule 1. It's insane that it's nationally Schedule 1, and it's really frustrating. So I can't comment on that any more details. Is there?
Is Anaquan and powered Lidocaine, do you consider them interchangeable, or do you have a preference in which case you find powered Lidocaine?
I don't use a lot of the hyaluronic acid products. I think of those as things you inject in joints, and Adequan things you inject under the skin or in the muscle, and that they work a little differently. I think hyaluronic acids injected into the joint alone have relatively limited duration of effect, and if I'm going to bother to inject something in a joint, it's going to have more than just hyaluronic acid. So it's either going to be cortisone or it's going to be Botox. But I just don't use a lot of hyaluronic acid. And I mean, they're both intended to help improve the joint status, but I think of Adequan as more of a preventive management, disease environmental modifier, whereas hyaluronic acid I think of as an intra-articular way to try and reduce pain temporarily in a really wrecked joint. But that's my limited scope of that. Anything else pop up?
The Airedale, you said the fracture was repaired, or?
Yeah, you want to see it? Oh. I just have my computer at the corner there. I'm not sure why this is banner shown there. That's her at about 4 months. That's the progress film 4 months down the road. Not a whole lot of activity at that central bone cancer site. I think it's under really good control. So that's it. Is there another question related to that offhand? Just curious to see it.
What you meant, I was trying to go, it says cell will solidify itself, or?
No, I don't have the original pre-op film. I mean, I have it back at the ranch, but I didn't bring it. So, any other questions? I would seriously consider the Galliprant medication. This classmate of mine that was part of the clinical trials, past president of IBAPM also, He has a dog that has ITP and is on like every second or third day corticosteroid therapy as part of their ITP management. And he's running Galliprant on his old dog with that ITP condition concurrently. He says I'm kind of holding my breath, but he's theoretically they should be something you could coordinate. You could consider having. And the cat thing, I definitely consider on cats if we have tough cases. But it's not like the EP4 receptor is all bad stuff. It's like all receptors. It's there for a reason. And there are a whole subset of EP4 agonists as therapeutic medications. It's not just an antagonist good, agonist bad. I have that in one of the slides. But the point is, we might see some mild GI signs, but it'll surprise you. And it's going to take a little time before we see some other like hepatic intolerance or idiosyncratic issues. But I'm very optimistic it's going to help us out safety-wise. So it should be as effective as the other good COX-2 guys, but safer. That's the way I describe it. Anything else? Questions about cocktails?
I think we have.
I'll leave it at that unless you have any other questions then, all right? Make sense?